all. This is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So, the discussion today is about a study that is published today in Nature. And this study, let me just very quickly show you the study's authors. So, this is drbeen.com. We'll talk about that in a second. This is a study published 25 May 2022, long COVID after breakthrough SARS-CoV-2 infection. And the lead researcher here is Dr. Zayed Al-Ali, I believe. Dr. Al-Ali is the director of the Clinical Epidemiology Center and the chief of research and education service at Veterans Affairs St. Louis Healthcare System. So this is coming from Washington University School of Medicine in St. Louis. And here is drbeen.com. There is a link in the description. If you like to have great medical lectures at a price lesser than $100, click that link and you can get it. So now let's start our discussion. Here is what they're saying. In a very quick summary, those people that have had vaccination and then had breakthrough infection, and actually veterans, those veterans who have had been vaccinated and then had a breakthrough infection, compared to those who only had the infection and not had the vaccine, again, these are veterans, the protection was only 15% for long COVID. That's a very minor protection by the vaccine. And why this study is breakthrough study, this data was not previously available. This comparison was not available at this large scale. You would see that there are about 12 to 13 million veterans that they have included, or whose data they have included in this study. So large study, very interesting. I was very curious always that after the breakthrough, does the long COVID occur? And I think we all had this idea that it does. But what is the protection? Is it less or not less? So that is what it is, only 15% less. So let's start our discussion. This is the paper, long COVID after breakthrough SARS-CoV-2 infection. And now I'm going to just very quickly go over my summary or highlights of it. So vaccine confers only partial protection from long COVID. What did the researchers do? What they did was they created multiple cohorts. This is a retrospective study. This is a data analysis. It's a cohort study. What they did was they took a cohort. Somehow my mouse has stopped to function. Okay, so my pen is not functioning anymore. So I'll have to just use the mouse, which is going to look really bad. But anyways, so here is a group. This group has breakthrough infection. The number of people here were 33,940. These were veterans who were vaccinated either with the BioNTech or with the Moderna or with J&J. And then they developed breakthrough infection. Number was 33,940. And they said that in their cohort, in the veterans database, 90% of the people were males, 10% were females. Even then, they tried to bring the data as close as possible to remove that gender-based confounding variable. However, they mentioned that as one of the weakness of the study. Then what they did was they created other groups which were control groups. So the control groups consisted of various 4 groups. Number 1, a contemporary no infection group. This was a group that was not vaccinated, plus it was not infected group. And this included, and this was contemporary, that means last year, for example, 4.9 million people, veterans. Then a historical group. Historical group was, they wanted to understand that these long COVID-like symptoms, is it possible that they have nothing to do with the infection? They have nothing to do with the vaccination. These were just simply something that can happen. So they took a historical group as well. That was a group of people, veterans, before the pandemic. So there were 5.78 million people in this group. Then they took another group who were vaccinated but never got infected. So that was no breakthrough infection in them. Then they made another group, as they call them, constructed another group that were infected with SARS-CoV-2 but not vaccinated. 113,474. So the number that I mentioned earlier, that number was when you compare those individuals that were infected but not vaccinated versus those individuals that were vaccinated and then infected. The difference between them for long COVID was only 15% protection from the vaccines. And how did they analyze these groups? They looked at the long COVID symptoms at 6 months after the infection in breakthrough infection group. And they started, of course, in the infection group as well, and they started counting 30 days after the symptoms. So if I get the symptoms today, they'll continue to count till 30 days are passed. Then from 30 days till 6 months, they would then at 6 months see my symptoms. And here are some of the excerpts from the paper itself. Today, I took a little easy route out for myself and I did not write a lot. Uh, I had done another lecture earlier for FLCCC and I was kind of tight on time. So, my apologies. So, here they said in their abstract, altogether, the findings suggest that vaccination before infection confers only partial protection in the post-acute phase of the disease. Now, look, we have been doing the comparison of vaccinated versus non-vaccinated, their case rate and their death rate and their ICU and hospitalization. That data is everywhere. This data, long COVID, is not available. This is the first study that is actually showing this data at this large level from the Veterans Affairs Hospital or healthcare system. So protection in the post-acute phase of the disease, post-acute phase being the long COVID. Hence, reliance. So now what does it mean? So not a lot of protection. So what do the researchers say? They say, hence, reliance on it as a sole mitigation strategy, it being vaccines. Reliance on it as sole mitigation strategy may not optimally reduce long-term health consequences of SARS-CoV-2 infection, which makes sense. They're presenting the data and they're saying that there is not much protection from long COVID. And then they're saying that means we should not use at least vaccines for this purpose, that, hey, they would help against the long COVID. They also then say in their limitations of the study, they mention that we have only seen up to 6 months. We haven't seen a year later, or now I'm paraphrasing their message, year or 2 year or 3 years. And they say, so consequently, we do not know what will happen further down the road. This is the data as much as 6 months. The findings emphasize the need for continued optimization of strategies for primary preventions of breakthrough infection and will guide development of post-acute care pathways for people with BTI. This is a very interesting statement. This is part of their conclusion. So if I quickly show it to you, this is this part that I was showing you. So what they're saying is the findings emphasize the need for continued optimization of strategies for primary prevention of BTI. So they're saying that breakthrough infection prevention strategies still need to be looked at. So some of us will look at that and say what they're saying are maybe the vaccines need to be optimized further. Some of us would say that they are saying we should figure out more methodologies as well, maybe more prevention as well. So there can be a host of factors that can contribute to it. What they are saying is our data shows not much protection from long COVID. So we need to look at the vaccines from that point of view once again. And then they're saying that the not only the continued optimization, and then they would say this will guide development of post-acute care pathways for people with BTI and those who have developed breakthrough infection. How do we manage them to reduce the possibility of long COVID outcome? That should be looked at as well. So very interesting. Now I'm going to go over some other parts of the excerpts. So this is the paper. I'm just going to give you a quick glance. So I've taken some parts of this paper, as you can see, highlights, and used them here. So the range of post-acute sequelae, long COVID, in various organ systems in breakthrough infection does not appear to be different than COVID-19 without prior vaccination. This was alarming for me. Do you know what they're saying here? Of course, you know, this is a rhetorical question. What they're saying is somebody is vaccinated versus somebody who's not vaccinated. The organ systems that can be involved in long COVID are similar in both groups. So it is not that we could say, hey, vaccine will help protect, let's say, neurological symptoms more for the long COVID, or vaccines would help protect against the long COVID symptoms in the respiratory system. So they're saying these sequelae, signs, symptoms, organ involvement is similar. That was kind of disappointing. Then they say our analysis suggests that this risk reduction of post-acute sequelae was most pronounced in recipients of BNT162b2, that is Pfizer BioNTech. So Pfizer BioNTech offered the best protection, and Moderna offered the best protection compared to adenovirus-based vaccines, I'll say J&J. So what they're saying is mRNA vaccines performed better. Again, overall performance is 15% protection compared to just infected and not vaccinated. And within that 15%, the better protection was by messenger RNAs and less by the adenovirus. So then they say, although these results recapitulate evidence of vaccine effectiveness in the acute phase of COVID-19, the mechanism or mechanisms underlying this carry through effect of risk reduction from the acute to the post-acute phase of the disease is not entirely clear. So they're saying is that, yes, we acknowledge that vaccine is helping against the acute phase. However, why is long COVID still so prevalent in the vaccinated as well? And they're saying we do not actually know the mechanism. However, one of their conjecture is one putative interpretation of these results is that the vaccine induced reduction in severity of the acute infection may then translate into less long-term risk of post-acute health outcomes. So they are making conjectures. Then at another place in their paper, they say, we also show that the risk of post-acute sequelae is higher in people with BTI, breakthrough infection, than in people with seasonal influenza. This was very interesting. So they actually created another group of veterans who had seasonal influenza, and then they saw the lingering symptoms in them as well, the influenza, and they saw that people who were vaccinated to SARS-CoV-2, then they developed the breakthrough infection, then they developed long COVID. The risk of developing long COVID in this group was more than people who were sick with influenza. Why did they talk about this one? Just to compare it and to say, if you think that this is all, let's say, flu based these were not SARS-CoV-2 infections. This was just simple flu or common cold, and that caused it. They said we actually compared it specifically to the flu group, and the flu group or patients had lesser sequelae compared to TBI or Bti breakthrough infections. So they say that this extends previous evidence showing that the risk of post-acute sequelae in people with SARS-CoV-2 infection was higher than those with seasonal influenza, and again emphasizes the importance of prevention of both SARS-CoV-2 infection and breakthrough infection. So they keep hammering on this, that we got to figure out a way to reduce breakthrough infections to help against the long COVID. The point is, let's say we give someone a vaccine and we say, you know what, this would help protect you against the SARS-CoV-2 infections. But if the risk of long COVID is similar, not similar, 15% better or reduced, then that protection still has a serious risk in it. Then they say our comparative approach shows that risk of death and post-acute sequelae were lower in the people with breakthrough infection, that is vaccine and then infection, versus people with SARS-CoV-2 infection without prior vaccination. So the risk of death was improved actually. Again, it was low. How low? That was 34% low. And the incidence of the long COVID was 15% low. Then they say compared to people with SARS-CoV-2 infection who were not previously vaccinated, this is again the same thing. I just have the data over here. Look at this data. So risk of death was, so hazard ratio 0.66, so about what, 34% improvement. And incident of the post-acute sequelae, 0.84 is the hazard, so 15% improvement. So that is the discussion. I want to stop this discussion here. I am actually going to go over the tables in the chit chat. So I want to keep this video short and sweet so you can kind of understand what this is, what they're saying, number one, and number two, maybe more freely share it as well. So thank you very much. Please like, subscribe, and share. And if you would like to support this work, there are links in the description. There is a link in the description for Dr. Been. There are about 1,000 lectures on Dr. Been's site, and the price is lesser than $100. I think you will be surprised if you see it. And then if you wanted to support it, there is a link for buying me a coffee, or using PayPal, or becoming a patron, or even becoming a Substack member. Thank you very much. I would see you on the Cool Beans Cafe live in a few minutes, and we will go over the tables and details of some of this study material. Thank you very much. See you soon.